Okay, that brings us to our final speaker, Dr. Roshni Kulkarni. Dr. Kulkarni is a professor of pediatrics and the director of the Pediatric Hematology Oncology Program at Michigan State University. She's a former director of the CDC Division of Blood Disorders, and she is one of the founding members of the Foundation for Women and Girls with Blood Disorders. Her research interests include global hemostasis and basic coagulation. This morning, Dr. Kulkarni will present the final talk on hemophilia carriers. Dr. Kulkarni.
Thank you, Maggie, and I want to thank the Foundation for inviting me and thank all of you for coming here. So I am on the other side of the placenta. The babies. So I'm not an adult hematologist, I'm a pediatric hematologist. But whatever is done in these women and whatever happens to them does affect their children. So that's my, that's where I'm coming from. So I'm going to kind of take you over this presentation. So these are my disclosures. We do participate in many of the clinical trials. So here is the first case, and this is an actual case, and I want to thank Dr. Nadia Ewing from California for asking me about this case, and that's how we got discussing it. So I thought, wow, this might be a good one to present here. So this is a 35-year-old Gravida 2 Para 2 pregnant female, 30 weeks gestation, and she seeks your advice regarding mode of delivery. Past history indicated that her factor VIII levels in the non-pregnant state were 25 to 28%, and this was done some time ago. She has had 2 prior normal deliveries, no postpartum hemorrhage, and has a history of menorrhagia. She now has 1 son with severe hemophilia A and high titer inhibitors, and as a maternal uncle had hemophilia, and her physical examination is essentially unremarkable. So, in your opinion, is this woman a possible hemophilia carrier, an obligate carrier? Does she have acquired hemophilia? Does she have von Willebrand's disease? All right, so we will go over this later on. So which of the following tests would you recommend in this woman? A factor VIII assay, a factor VIII inhibitor assay, antiphospholipid antibodies, or do a DDAVP challenge test? All right. Her factor VIII levels come back as 65%. So what is the mode of delivery you would recommend? Vaginal delivery, vaginal assisted delivery with vacuum or forceps, a planned C-section, or a C-section if she happens to go and needs it? All right. So following an uneventful delivery, she is discharged but returns a week later with heavy vaginal bleeding, postpartum bleeding. Her laboratory shows her factor VIII levels to be 28%, von Willebrand factor levels to be 95%, and antigen 105%, and her platelet count was normal. So what is your first line of therapy? Von Willebrand factor concentrates, intranasal DDAVP and antifibrinolytics, factor VIII concentrates, bypassing agents, or a hysterectomy? All right. So let's look at some of the characteristics of this carrier or female hemophilias. As you all know, carriers are female who have one affected X chromosome, and there are different mechanisms, extreme lionization, X hemizygosity, etc., which can give you a symptomatic carrier. So lionization, which is inactivation of one of the X chromosome, causes factor VIII or factor IX levels of about anywhere from 22 to 116%, and normals are roughly 50 to 150%. So carriers traditionally are described as asymptomatic or symptomatic, and those with factor levels of between less than 30% to 50% may have bleeding symptoms, and they should really be regarded truly as mild hemophilia. And there was a publication in Blood which showed that some women with levels as high as 40 to 60% also experience bleeding episodes. So there was this wonderful publication from the National Hemophilia Foundation called Carrier Barrier and Carrier Confusion. So a carrier, if you look at it, is a genetic designation and not a clinical diagnosis. A designation of female hemophilia instead of a carrier allows for insurance coverage and access to comprehensive care. When you talk to a lot of these women, it's really fascinating that some of them, when they have these bleeding episodes and all, take their son's factor and infuse themselves. And we can't have that. I think we really need to give these women a chance of seeing hematologists, receiving comprehensive care in the treatment centers. And I should say that at this point that Dr. Barb Conkle, who's the vice president of our foundation, along with a collaborative effort with the National Hemophilia Foundation, Biogen, IDEC, and the American Thrombosis Hemostasis Network, has set up a huge collaborative issue called My Life, Our Future, and hopefully that will be expanded to include genetic diagnosis of those not only with hemophilia, but also carriers. So we are really excited about this coming to the United States. So what are the types of carriers? So obligatory carriers definitely are all daughters of a man with hemophilia, mother of one son with hemophilia, and at least one other family member, such as a mother, maternal uncle, or grandfather, nephew, cousin, mother of two or more sons with hemophilia. A possible carrier are all daughters of a carrier. So remember, our case had a son with hemophilia and an uncle with hemophilia. So the possible carriers are all daughters of a carrier, mother of one son with hemophilia, and no family history of carriers, sisters, mothers, maternal, grandmother, aunts, nieces, etc., of the carriers. And we all know that Queen Victoria is perhaps the most famous carrier. So when I teach medical students, I usually tell them that hemophilia is a disease of royalty and thrombosis is a disease of presidents and vice presidents. Because if you look at thrombosis, you usually Al Gore had it, and Nixon had it, and Dick Cheney had it. And so a lot of all these celebrities have thrombosis. That's, I think, from too much traveling. So the World Federation of Hemophilia recently has a very nice definition of carriers, and they call it hemophilia, whether it's male or female, and the definition is the same. Less than 1% is severe, 1 to 5% moderate, and 5 to 10% mild. They define symptomatic carrier as a woman with a factor level of 40 to 60% who experiences bleeding. So let's talk about this a little bit and see, should we really refine this diagnosis a little bit more? Are there any other ways to define these carriers? So the question often comes is when and why to test these women and girls. So as a pediatrician, I usually see not only the patient with hemophilia, but the sister or the mother, aunts, uncles, the whole family comes sometimes to the treatment center. So the idea to test for carriers is to prevent bleeding episodes and assess the need for hemostatic support. As I mentioned before, they don't have to have that low a level of clotting factors for them to bleed. They bleed at a pretty high clotting factor level. And it affords reproductive choices. You can discuss preconception care, in pregnant women. And oftentimes, we talk to the obstetricians or gynecologists to see what should be done with the babies. When to test is controversial. So, and in many publications indicate that for symptomatic carrier, the best time to test is before puberty, because they have an increased risk with procedures and tooth extraction and all, and so they may have an increased risk with pregnancy or ovarian, heavy periods, etc. Asymptomatic carriers, most of the people recommend that they be tested at puberty or adolescent as a part of the preconception care. Many others believe that if you ask the patients, and these are multiple surveys that have been done, which have shown that if you ask the patients, they would prefer that to test all potential carriers at birth. So this is very different between what the physicians perceive or the providers perceive versus the patients. One has to consider age, cultural, psychological, and religious beliefs, because in many cultures, if you're found to carry a disease, then your chances of getting married are really reduced. So one has to take that into consideration. So what are the pros and cons for testing in childhood versus delaying testing till adulthood? So not only you can do education and get insurance coverage. I think for us in this country, that's an important issue, because many of these patients cannot get appropriate treatment, cannot get coverage, cannot get comprehensive care because they have no insurance. The cons of delaying the testing till adulthood is that it can harm child's self-esteem. They may feel that they have a disease, and it deprives autonomous informed decision of the child, and adversely affects the capacity to form positive relationship. Some carriers, feel that they should reveal their carrier status to their potential partners, or sometimes feel they cannot get married because they have a carrier status. And of course, as I discussed before, there are cultural issues. So what are the tests one should do? As I said, screening tests definitely needs to be done, because those who have very low levels can be diagnosed, or at least need to be identified as having abnormal screening tests. Then the factor VIII assays, von Willebrand workup, and factor IX assays. And 20% of the carriers, as I mentioned before, may have normal factor levels. Now, genetic testing, I think genetics testing, I'm amazed that Europe does a lot more genetic testing of carriers than United States, and hopefully with this My Life program, we may be able to catch up with Europe in doing genetic testing of all carriers. Now, what about bleeding assessment tool or bleeding scores? So this is a certain, and I think if you go to the ISTH scientific subcommittee website, and look under the bleeding assessment tools or bleeding score, there's a Tosetto bleeding score. And what this bleeding score is a series of questions and assessments that have been done, which look at bleeding after tooth extraction, epistaxis, menorrhagia, postpartum bleeding, etc., going from a score of -1 with none of those bleeding episodes to a score of 4 or so, where there is provider intervention or blood transfusion or surgery or something undertaken. So can that bleeding score be applied to this population? So when we look at the CDC's universal data collection, this is the Centers for Disease Control, which is in our neighborhood. As you can see in the, you can see that in the database, there are females with factor IX deficiency, factor VIII deficiency, and hemophilia carriers. Now these have been, okay, so these have been reported by the 135 or so hemophilia treatment centers. And if you look at hemophilia carriers, so there are about 5,461 females, and you can see that 1,000 of those females most of the hemophilia carriers, most of the factor VIII deficiencies are male patients with hemophilia, almost 97% of the 14,000 total factor VIII deficiency patients, and about 2% are female carriers or female hemophilia, or people have identified them as female. Now, this was a study done by the Centers for Disease Control when I was there. It's called the Female UDC, Universal Data Collection. This was done at 17 centers in 2008, and some of the results are published in the journal Hemophilia. As you can see, these are the different kinds of bleeding disorders that we're seeing amongst females, and the most common one, of course, being type 1 von Willebrand's disease. And you can see that factor VIII deficiency comprised 11.7% of this population of 562 females, and factor IX was about 3%. When you look at the sites of bleeding in these carriers, so these are all different studies which have looked at, where do these women bleed? And the first one is in Amish population of 64, and the others are from Europe. As you can see, most of the bleeding occurs in tooth extraction, post-surgical bleeding, almost 40%. These are percentages. And if you look at menorrhagia, postpartum hemorrhage, most of these occur in these carriers. What is also very interesting is that joint bleeding is also seen in these patients. And for the CDC, I think exposure to blood and blood products is an important issue. As you can see, some of these patients do get exposed to blood and blood products. So if you look at joint bleeding amongst females with bleeding disorders, about 47% of type 1 von Willebrand's disease had joint bleeding, and factor VIII, about 12%, almost half of them did have joint bleeding episodes, but in fact, it was less in patients who had factor IX deficiency. What about central nervous system bleeding? Again, it's uncommon in females, but it does occur. So I just want to raise awareness that joint bleeding and CNS bleeding can occur in these women. So in the Amish study from Dr. Anjali Sharath Kumar, this was an excellent study of Indiana, Amish population. What she found was that if you look at the numbers with the tooth extraction, there were 42 patients, of whom 13% had it, but almost 78% had not only positive bleeding symptoms, but also a bleeding score. Remember, I talked about the Tosetto bleeding score of greater than 3. And especially in those who required treatment, almost 100% of those patients had this high bleeding score. So you can see that it's just not enough measuring the factor VIII or IX levels, but also we should add to our armamentarium a bleeding score and see where do these patients stand with reference to their bleeding score. If you look at their mean factor IX levels, you can see their levels were kind of similar, 48, 43.9 plus or minus 11 versus 58.1. A lot of these women also had menorrhagia or heavy menstrual bleeding and postpartum hemorrhage. So these are the three major things that you will see in these women. So in the Indiana Amish study, there were 12 subjects with bleeding score of greater than 3 and 51 with a bleeding score of less than 3. And their factor IX levels, you can see them, were slightly less in those with the bleeding score of 3 or greater than 3 versus those with a bleeding score of less than 3. There was an abstract at the World Federation of Hemophilia, and that was published in Hemophilia just recently. And from what I could glean from the abstract was that there were 14 subjects, of whom 50% of cases had a bleeding score of 4 or greater. 31% cases had bleeding score of greater than 4. So you can see there factor 8 or 9 levels less than 0.4 or 40%, and the number of subjects who had a bleeding score of 3.5 were about 14, and those greater than 40% were seen in about 84 subjects. So when you look at carriers versus non-carriers and look at their factor 8 levels, there's a kind of an overlap. Clearly, there's a wide range in the carriers status carriers that goes on to a normal range. And as mentioned before, besides the issues with tooth bleeding and all that, if you look at their menstrual period characteristics, most of them with levels less than 40% undergo excessive blood loss, have iron supplement or require iron supplementation, and have a quality of life issues with restrictions in daily life. And those are outlined in those blue numbers. So what about phenotype and genotype association? There were 46 carriers with known factor 8 gene mutation. And you can see here, about 39 of them had inversion 22 mutation, and intron 22 inversion mutation, and about 61 had missense mutation. Those with the intron 22 inversion had increased number of male relatives with severe hemophilia, and you can, I'm sorry, I can't. Right here. And they had more hematomas, prolonged menstruation, prolonged bleeding after giving birth, and prolonged bleeding after tooth extraction. So this was more common in those with the inversion 22 or intron 22 mutation. So when you look at all these genotypes, the strongest bleeding risk was seen in 18 patients with nonsense mutations and intron 22, as I mentioned before, and missense mutation. If you look at the no bleeding risk, most of them had missense mutation. So this showed the correlation between the genotype and the phenotype. So the conclusion from these studies are factor activity level resembling mild hemophilia are associated with bleeding, and most of these women have mildly reduced factor activity, and menorrhagia affected quality of life in these individuals, and the relative risk of post-op bleeding is much higher in these carriers. Those with intron 22 and nonsense mutations had strong bleeding tendencies, and bleeding score of greater than 3 had a mean factor 9 levels of 42%. So what about pregnancy issues? We all know that the levels of factor 8 rise in the second half of pregnancy, while those of factor 9 remain constant during pregnancy. So they have women whose levels are below 50% may bleed with invasive prenatal diagnostic procedures. They may have termination of pregnancy, spontaneous abortion, or may have bleeding with epidural and cesarean delivery. Women, however, have some conception options. They can undergo in vitro fertilization or pre-implantation genetic diagnosis, and I'm happy to say Dr. Carol Casper is a proponent of this IVF and has been involved very closely with a case from Ecuador, whom she helped, or Bogota, I'm sorry, Colombia, and she may be able to make some comments on those. And the second option that women have is in vitro fertilization with egg donation from a non-carrier, and of course sperm sorting, and then choosing the sperms with the X chromosome. And I'm not going to go into detail, but these are diagnoses in the first trimester, second trimester, and third trimester. Clearly, in the first trimester, you have chorionic villus sampling or DNA analysis, or it's called a YPCR, or transvaginal scanning later on in the second or third trimester for fetal gender. It can be done as early as 16 weeks, and gender determination of a male fetus. In the later trimesters, you have ultrasound and amniocentesis. So what kind of choices do women have, and what do they choose? So this was a study which showed that there were about 112 out of 207 carriers who were genetically confirmed. Early prenatal diagnosis or first trimester diagnosis was carried out in 48 out of 112 of these women. There were 26 affected pregnancies, and about 82% of these women opted for termination. The characteristics of those women who opted for termination were that they had a liberal view, they had a family member with severe hemophilia, and they were not very religious. Late prenatal diagnosis was done in 64 of these 112 women. There were 4 affected pregnancies, and there were no terminations. And the characteristics of these women were, they were older women, their birth year was 1970, they had a previous child with hemophilia. I do not know the severity of the hemophilia of the previous child, and they found that there was no influence of bleeding score in these cases. So the complications during delivery and during pregnancy, besides spinal hematomas, which can lead to compression and paralysis, there are patients who can have vulvar hematoma. Now, as a pediatrician, what we did was looked at babies with hemophilia and their risk of intracranial hemorrhages with the different modes of delivery. So the mode of delivery is very controversial still. As you can see, if the mother was a known carrier, the intracranial hemorrhage rate was 1.3%. There were only 2 babies. And with elective C-section, there was none. If you look at babies, and these were 565 babies, who came with a bleeding symptom, almost 8% of them had an intracranial hemorrhage with vaginal delivery, and about 3.6 or 1 baby had intracranial hemorrhage with elective C-section. Now, what is missing in here is asymptomatic intracranial hemorrhage. There was a study done in Chapel Hill, North Carolina, where they did MRI of all these all babies. These were normal babies. We don't know how many of them were hemophilia. So in normal babies with MRI, the rate of bleeding in the brain is about 27%, very high. So it's just this, and that was with vaginal delivery. So I think we really need to look at these babies just not as symptomatic intracranial hemorrhages, but also as asymptomatic intracranial hemorrhages. We had proposed a study to the NIH. Unfortunately, the numbers are so small that we really will need an international study to answer what is the best mode of delivery for these carrier women, and what is the rate of intracranial hemorrhages in these babies born to these women. So if you look at postpartum hemorrhages, primary unaffected women is about 5%. It's about 22% in von Willebrand's disease, and about anywhere from 10 to 19% in hemophilia carriers. Secondary postpartum hemorrhages can occur in anywhere from 3% or to 2% in these patients. So what are the management guidelines? So there isn't very much published, other there is a wonderful monograph at the World Federation of Hemophilia. So one can use not only factor concentrate, but also tranexamic acid, which is now available for our patients with heavy menstrual bleeding as Lysteda. And one can also use oral contraceptives in some of these non-pregnant cases. So what are the future issues? I think we need a definition. We need to further refine the definition of hemophilia carrier. I'm glad that World Federation did come up with the definition saying that you cannot really make, hemophilia in a male is also a genetic diagnosis. We don't call them male carriers of hemophilia and female carriers of hemophilia. We just call them hemophilia. And I think that's what we need to do. The question is, can we add bleeding score to that to further refine their diagnosis? Is there a difference between hemophilia A and B carriers? What about age of diagnosis? When do they get diagnosed, and what are the lifespan issues in these women? And there should be a provider education, there should be patient education, and there's cost and there's acceptance rates which should be taken into consideration. So the clinical issues are, what are the risk factors for bleeding? Is it dependent on the mutation, as one of the studies show? Blood group, their von Willebrand factor levels, their combined factor deficiency. Recently I saw a woman who is a carrier and had a platelet function disorder. So sometimes these combined issues do come up in these patients. and carrier-specific bleeding score. Now, there is no data on the treatment regarding safety and efficacy of factor concentrate in the treatment of bleeding episodes and surgery in female hemophilia carriers. So we really have work to do there. And what are the contraceptive choices? And the reason that factor concentrate is important is because a lot of these women have high levels of factor. So whether giving them factor concentrate at the same rate that we do for males with hemophilia, would it lead to a risk of thrombosis? Now, regarding pregnancy issues, we talked about the mode of delivery and impact on mother and baby, and there is really not much literature about pediatric carriers. And are the symptoms of bleeding same in mild hemophilia regardless of the sex, type 1 von Willebrand's, and carriers in female? And can we compare joint range of motion of hemophilia carriers and female with von Willebrand's disease and correlate it with factor levels? So this is just to show you joint range of motion in females with von Willebrand's disease. You can see the red line is type 3 von Willebrand's disease. The yellow one is the type 1, which kind of goes along with the normal black one. And the type 2 seem to do better. Now, we have no idea where females with hemophilia plot when you plot like this. There's a similar plot for males with hemophilia showing them that they're in the mild, moderate, and severe hemophilia have different joint range of motion restrictions. So, coming back to our case, this is our 35-year-old gravida 2 para 2, and in non-pregnant state, her factor level was 25 to 28%. She had 2 prior deliveries and no postpartum hemorrhage. She has 1 son with severe hemophilia and a maternal uncle with hemophilia. We don't know the severity. So, is this woman a possible hemophilia carrier? Is she an obligate carrier? Or does she have acquired hemophilia? Does she have von Willebrand's disease? All right. So obligate carrier because she's a son with hemophilia and an uncle with hemophilia. That puts her into that category. Which of the following tests would you recommend? Factor VIII assay, factor VIII inhibitor assay, antiphospholipid antibodies, or a DDAVP challenge test? She's pregnant. Very good. So her factor level, 8 level comes back as 65%. So what is your mode of delivery that you would recommend? Vaginal delivery, vaginal assisted delivery, planned C-section, or C-section? Okay, so I did expect a little bit of controversy here. So in this case, I would have recommended vaginal delivery, knowing very well that one, and this woman already had 2 children by vaginal delivery with no problems. And so to subject her to a C-section would mean she would be exposed to factor. And of course, if she was bleeding, one would do that. So following an unlimited delivery, she comes to you with postpartum bleeding. And so what is your first line of therapy? Von Willebrand factor concentrate, intranasal DDAVP and antifibrinolytic factor VIII concentrate, bypassing agents, or hysterectomy? Okay, so this question was a little tricky, and both B and C could be correct, because if she's actively bleeding, has heavy bleeding, then clearly one should give her factor VIII concentrate. However, if you have time, she's not bleeding very well, one could do a DDAVP trial and give her some tranexamic acid to see whether that would be helpful. So I just want to acknowledge all these people who helped me, and thank you very much. Yeah, I can't see them. Yes, go ahead. Thank you.
Sometimes it's hard to distinguish a hemophilia carrier from a von Willebrand disease in women. What's your approach to those hard cases?
You mean in terms of testing and all that?
Testing, genetic testing, or like you said, the platelet function may be abnormal.
Correct. So we do both, actually. We do testing for von Willebrand's disease, and the testing for von Willebrand's disease does include a factor VIII. So for the hemophilia A, it becomes easier. For factor IX, of course, one has to do it. And more lately, in some of these women who have heavy menstrual period, who do not respond to any of the oral contraceptives or any of these things, we end up trying to look for their platelet function, their dense granule deficiencies and things like that. And we're finding more and more of those cases. So this other woman required platelet transfusions in addition to her, factor concentrate. Yeah. I'm sorry, I can't see. The light is on my face.
Dr. Bassem al-Beiruti from Saudi Arabia. Just I'm glad to see that there is Women and Girls Foundation, but women, when it comes to pregnancy, we need to evaluate the father, because I didn't hear about the father evaluation of hemostatic, what's his status, because this will affect the mother and the baby and the pregnancy outcome, and the implication that nothing from the fetus will go to the mother is not true. Microchimeric studies proven that the mother will be affected and the manifestation happening to the mother will be affected. So I think it's
yes,
important.
so you're absolutely correct. So in one of the slides that I showed, I did show the impact that the intron 22 inversion mutation had more male carriers with severe hemophilia. So clearly the phenotype of the father does affect, you can see that the mutation in the mother is, and the bleeding history in the mother did reflect, what happened to the family member with
And we didn't hear what is the status of the baby, because you are recommending vaginal delivery, but what if this baby is hemophilic? Right. So why you will expose him to this, why not C-section where the baby can be, unless we have pre-genetic testing or amniotic fluid that we know that this baby is normal. I think doing vaginal delivery, yes, we can bypass with the mother with DDAVP or factor VIII, but if the baby has hemophilia, we might put him at risk if he is boy. At risk of
so I deliberately didn't include information on the baby, if you notice, because I didn't want people to get the thing into it. Let's say we didn't know the baby and the mother came to you towards the end of her pregnancy and really, or in labor, then you would really have the choice of having either, a vaginal. You probably wouldn't have much of a choice. But if the baby is severe hemophilia, clearly one of the choices you have to put in front of the mother is to have a C-section. I think most C-section is very safe, and I think Andy James will. Oh, okay. And I have one last question. What is that?
So I was wondering, with regards to your approach, do you have an approach in deciding which carrier patients get DDAVP challenges, and is it based on the residual factor VIII activity, or is it based on their bleeding symptoms?
So what we do in the carriers is in the non-pregnant state, depending on their, if we know that they're a carrier and they are symptomatic, we do get a bleeding score, and it's really not dependent on bleeding score. It's dependent on the factor level to see whether we can get a rise in their factor level.
Thank you.
I think that's the last question. Thank you very much.
Okay, so this brings us to the close of our symposia. We would like to thank our distinguished speakers for their outstanding job and the audience for your enthusiasm and interest and participation. We hope this is helpful to you in your practices. I'd like to mention that in early 2013, this symposium will be archived on the website, fwgbd.org, for reference or for revisiting any of the topics. And a couple housekeeping points. Please complete your CME evaluation. This is required for the Foundation's metrics. And please turn in your audience response devices. Thank you.